Tom Lee, first of all, I'd just like to thank you on behalf of the Nuffield Trust and the Commonwealth Fund for taking part in this interview. I wanted to ask you a bit about one of the kind of key ambitions of the Affordable Care Act of health reform in the United States has been to drive up quality at the same time as containing costs, and that's the biggest challenge really is to kind of get costs down. And of course, for provider organisations, this could be seen as a massive threat as much as an opportunity. What has it been for your organisation? A threat or an opportunity?
Well, of course, it's both, and it feels like a crisis. It feels like there's tremendous pressure on us to change what we are, to change from being a relatively loose configuration of academic hospitals, community hospitals, doctors in the hospital and in the community, and actually become an animal that works together to take better care of very complicated patients and populations of patients. And that means collaboration in ways that we have never done before. And we've all been for it intellectually, but now we actually have to perform, and it's stressful.
Can you explain to me how accountable care organisations work and whether you are now an accountable care organisation?
Well, we are accountable, certainly, because we have signed contracts where the total medical spending on about 500,000 people will determine our financial performance as an organization, their quality as well as the total cost of care. The tougher question is, are we an organization? And I think that will be determined by what happens in the next several years.
So tell me about how you're addressing these challenges that you've described.
I think the most immediate thing that we're doing is we're focusing on those 5% of patients who are 50% of costs. And for those 5% of patients, they are the ones with the biggest quality issues, the most disutility of care. So our conscience is completely clear that we're trying to do good and also save money at the same time. So the very first thing we're doing is funding high-risk patient managers, case managers, who are embedded in our primary care practices to try to follow those patients. One case manager for 150 to 225 patients, to pick them up when they leave the hospital, to try to keep them from going back in. It's not rocket science, but it is a lot of work.
So success in this regard is measured by reducing hospital utilization for these patients?
Well, it's reducing overall spending. And there are times where a hospitalization might help reduce overall spending. A timely hospitalization might end up preventing another one where a patient goes to the intensive care unit for a long period of time. So the goal really is improving patient outcomes, but doing it in ways that also reduce the total amount of money that gets spent.
And one of the challenges that we're facing in the NHS is doing what you've just described, which is taking better care of people with chronic conditions, those who are at most risk of hospitalisation. But of course, if we're successful, it means that we're actually looking at smaller hospitals over time. How do you approach this problem? Because hospitals are powerful players in the system, and hospitals don't want to lose.
Your point is a good one, and your concern is a real one. And some people question, will hospitals ever really have their hearts in the game? Because if we're successful, it will empty out hospital beds. It will mean facilities should close. So in truth, I think it has to be a different kind of animal that takes on this task. It has to be an animal that is focused really on population management, what's happening to a population over time. Now, hospitals are very often at the core of organizing these ACOs in the United States because, frankly, everyone else is too disorganized. They're the only organizing force out there. But will their hearts be in it? I think the ones whose hearts are not in it will probably not be successful for very long.
We've heard about examples where there are all sorts of interesting innovations relating to ACOs and other forms of payment reform, but they still only apply to a small proportion of providers in the United States. Do you have any thoughts about how this will be scaled up in the United States?
Well, you know, really successfully driving change through the dissemination of innovation curve That's something we worry about a lot, particularly where I come from, the Brigham and Mass General, where frankly we've always given more emphasis to coming up with the great idea, writing about it, doing a little study, than driving something all the way through. And we know we need to drive our systems all the way through if we're going to be successful in these contracts. So how do you do that? Well, I think that we know that measurement is a core strategy for us. We can talk forever, but we won't spread things all the way through until we have actual data in front of people and bring it back quarter after quarter. And the data have to be about patient outcomes and the real cost of care. So investing in that measurement infrastructure, starting to measure data, which are not perfect, but then make them better, that's a major part of our strategy. And give people the message, you might as well try to help make the data better because it's going to keep coming. So data on outcomes and cost. I do think most of my colleagues, all of them as far as I can tell, they're basically good people who will respond to data and try to drive improvement. I think another thing is actually having financial incentives and non-financial incentives, peer pressure, but having some portion of people's income tied up with how we're doing overall. That is a major leap. People in our organization want to be compensated based upon things which are completely within their control. We actually have been trying to consciously change that for them to understand that part of their compensation is dictated by how well we work together. And we'll see how it goes. The time will tell.
Tom Lee, thank you very much for talking to us.